Madam, next I invite Dr. Anju Kuriakose to present her case of endophthalmitis. Dr. Anju Kuriakose, she is UVA consultant, Chaitanya Eye Hospital and Western Eye Hospital, Kochi.
Good afternoon to one and all present here. Thank you KSOS for this opportunity. I am Dr. Anju Kuriakose. I am going to present an interesting case. So a 30-year-old male presented with complaints of blurring of vision in his right eye for the past 2 days. No history of pain, redness, watering, photophobia. No relevant past history, no history of trauma or no comorbidities, not on any medications. On systemic examination, he is conscious oriented within vitals were within normal limits. On ophthalmic examination, best corrected visual acuity in the right eye was 6.9, left eye was 6.6, anterior segment and IOP were within normal limits. On fundus examination, right eye dilated fundus examination, media haze was noted and multiple yellow fluffy round lesions were noted in the superior along the superior arcade, and rest of the retina was within normal limits. Left eye fundus examination was within normal limits. On further investigation, we ran the OCT on the lesion, which was on the superior arcade. On the lesion showed hyperreflectivity of the inner retina with posterior shadowing along with vitreous aggregates, extending into the vitreous cavity. There's another picture showing again the OCT running on the lesion. So we sent the patient for UVA panel of investigation, out of which HbA1c was 8.5 and deranged blood sugar levels. Rest of the investigations within normal limits. On probing on the history, because he is not aware of his diabetic status, he was given a history of native treatment for his varicose vein, which includes maybe he's doubting of including steroids in that. So urgent physician referral was sent for systemic control and was started on topical 1% oriconazole therapy. He was reviewed after a week. His vision was still the same, but on OCT, but his lesions were seemed to be resolving. So when we ran the OCT on the lesion again, which was previously, we could see the significant difference of the hyperreflectivity of the inner retina was significantly decreased with this vitreous aggregates. So this is the picture with first presentation of OCT showing the typical hyperreflective lesion on the inner retina with vitreous aggregates extending into the vitreous cavity. And this is the second one. The first presentation, which is hyperreflective to the lesion, which is termed as rain cloud sign. So provisional diagnosis of endogenous candida endophthalmitis was made because rain cloud sign in OCT is typical of candida specific, which was published previously in 2018. So take home messages, rain cloud sign in the OCT is candida specific. Appropriate investigation can clinch the diagnosis, because when we ran the OCT on the lesion, we could see the picture of the typical rain cloud sign, which gave the final diagnosis for this patient. Thank you. Inverted snowing sign, that was actually in a photo essay recently published, because they were feeling if we I have pictures on that. Adon open cheyavo. Alla, I have pictures for that. So this was the first first sign which was published in 2018. And this was a photo essay we were mentioning. And in that, in the inside picture, you can say it is inverted. They have inverted the image and they have mentioned about this inverted snowing sign. This is that photo essay. And one more thing is there is one, they had one classification for this. There are 4 types on that. I think Madam will discuss more about it.
On fundus examination, what are the typical things that we are looking out in a case of fungal endophthalmitis?
I actually have to say that, history is actually key, rather than examination, and particularly in endogenous fungal endophthalmitis. More than the clinical examination, it's the history that gives you a clue. And with fungal, so when you started the presentation, you put it as a healthy patient, but this patient turned out to be a diabetic.
Yes, ma'am.
And not to be taken lightly, uncontrolled diabetes is probably the most common risk factor for endogenous. And if I would like to repeat it, uncontrolled diabetes is the most common risk factor. Okay, you tend to think that an endogenous end of patient is going to be a very sick patient, admitted in ICU. That's not the case. And with fungal endophthalmitis, you also have to ask for history which dates few months prior to the onset. So any kind of ocular inflammation which happens in a patient after hospitalization, after some kind of surgical intervention, particularly notorious in the GIT or urinary tract. Those two areas, typically causes a fungemia, so to say. It can have, it can be few months prior to it. So you need to ask, what happened in the few months preceding the onset of the eye symptoms. So you're not asking for a history, 1 month ago, 2 months ago. This is exactly the, how you need to take the history. Then you need to, any inflammation, after a hospitalization or any kind of intervention, you need to think of endogenous end of. In the fundus findings, we actually post COVID, we saw a lot of fungal, endophthalmitis, and typically, they can have these snowballs in the vitreous. So some of these cases, they look like toxo, but the presence of snowballs is a clue that would favor, go in favor of fungal. Similarly, that kind of pre-retinal aggregates in rain cloud sign. And also, classically, what happens is the infection comes into the choroid, it breaks through into the retina and then comes out into the vitreous. So if you do an OCT, you can see that it's like a volcanic eruption, like you can see the cone, coming up like that. So these are all features, which should make you think about fungal endogenous endophthalmitis. So you can mistake it for intermediate uveitis. So that's one differential diagnosis you should keep in mind. But intermediate uveitis will not have a retinochoroidal lesion. Yeah.
Was any blood or urine culture done here? Or vitreous biopsy?
No, within after 1 week, patient lost follow-up. Only because we don't have follow-up after 1 week.
Madam, if you have a case of endogenous, you're suspecting a fungal endoff, would you start systemic antifungals and give an intravitreal voriconazole?
So normally, the thing is, we would refer them to retina department, but we have managed some of the milder ones with oral fluconazole. This is the Candida endoff with excellent results. But you have to give it, for a couple of months, 2 months. It's also very important, although most of the time the blood and urine culture, almost always comes negative because the seeding would have happened, months ago. But nevertheless, for legal reasons, you should do blood and urine culture in all these cases and control the systemic risk factors. Yeah.
Ma'am, the post-COVID were they all due to high sugars?
Most of them had, high sugars. Most of them did. Or they were hospitalized. They had, steroids during that time. Yeah.
Madam, when to suspect an infectious etiology when you are treating a uveitis, considering it as an immune pathology? When will you suspect an infectious etiology, especially endoff?
So to answer that kind of briefly, any patients whose immunity is compromised, either from HIV or iatrogenically, the patient is on immunosuppression, any inflammation in that patient, any uveitis, is to be considered infectious until otherwise proven. Okay. That is one. Two is, like I said, any inflammation whose onset is after surgery or in hospitalization. So this could be an ocular surgery, or it could be some surgery in the body, or any kind of IV fluid or hospitalization. Anything which has started after that, you need to think of it as infectious. And generally, like I said, most retinitis, you would consider infectious. Any hyperpion uveitis, again, you need to rule out infection, before. So these are my top four.
Thank you.